objective, because your learning objective was, okay, I want to be able to assess a stricture. I want to know how to approach it, and I want to know. So we're going to go from first principles, right? Let's go in a little bit. We've got fluoroscopy, but we haven't got anything, we haven't put anything down, so the fluoroscopy is not going to help you for now. So what do you see for now? Yeah. Yeah, so do I. What should we need to do to this stenosis to approach it a bit better? Yeah, great. So let's put some Infocol down to Naz. If we could have some Infocol, that would be great. Oh, it's already there. Incredible. So I'm here with some very talented nurses today. Caroline, who needs no introduction to Friends of Geeks. Thanks, Caroline, for all your efforts getting this set up today. It's a new setup, so prepare with us for a bit of teething issues with fluoroscopy. We've got Tanaz. I won't try and pronounce your surname, Tanaz, on camera because I'll be embarrassed and so will you.
Thank you.
But Tanaz is one of our very dedicated and friendly, helpful endoscopy nurses that we have here in Ghent. And I also thought I saw Manu at some point. Is she here somewhere?
She will come back.
Manu will join us later as one of our very young and very talented colleagues in the nursing. So we're very grateful and lucky to have them. Okay, now let's have a look at this again. So that's actually now looking a bit better than it did, isn't it? I was thinking this was a pinpoint stenosis, and just by taking out that, we've done something. All right, suction some more of that fluid so we can get an idea. So the first important point is assessing the nature of this stenosis, okay? So this is a very interesting case already, you can see it, right? Thank you for pausing, fantastic. So let's describe this.
I think it's fibrotic circle.
So it looks exactly like yesterday, remember in the Barrett's course, we talked about nature of a scar.
Yeah.
This is a perfect example of a scar, and in this case, it's completely circumferential.
Yeah.
Why is it a scar? It has those fish swimming in all different directions, these capillary pattern, it's wide, and it's also in this case helpfully forming a ring.
Yeah.
To make it, yeah. So this is how long would you say this particular one of the multiple stenoses here in this patient is? Yeah.
Just this ring?
Yeah.
More, say...
Short.
Yeah, short.
Yeah, very ultra short, right? Just that, nothing else. Yeah, okay. So that's important. So there it starts with assessment of stenosis. Can I assess it endoscopically?
Mm-hmm.
And in this case, you can assess it endoscopically. You can see through it.
Yeah.
So therefore, I don't need a nasogastric scope. I don't need fluoroscopy. I can make a decision based on this one endoscopic image that you've frozen, which is fantastic that you did it. So based on this image, if we cannot pass here, what could we do to open this? Something about a previous report?
Yeah, if it was...
Yeah, what they dilated it to before.
Yeah.
Like what sort of distance that it got dilated to before. I think if you're not sure about a stenosis, about pushing the scope through, you have two options. One is to ask someone else to feel and see what they think. Another option is just to take a dilation balloon. But I think that in that order, ask someone else, but if it's not someone, take a dilating balloon, right? Mm-hmm. One other interesting thing about this stenosis, and something we should mention to the audience, is that this stenosis has quite a fibrotic component. Yep. And maybe if you take a dilating balloon, it will tear in a particular orientation. And maybe it's quite good for incisional therapy.
Yeah, and that's what I wanted to ask. Is it good for like
I think so. I think so, yeah. So
it seems really quite fibrotic.
Yeah, yeah. And I mean, let me just have a second so I can show. I would needle knife pakken alsjeblieft.
Yeah.
So the first question is, can I pass? Because if I can pass, then okay. So we are going to, how do you try to pass in a deconstructed way? What should you be trying to do? In my view, you should be trying to center the endoscope in the stenosis, right? And then you should gently apply pressure. And it should not be hard. You should just keep on applying standard pressure, keep the pressure on. I'm pushing my right hand forward a little bit, right? And I kind of want it to fail because I want to show incisional therapy. So I'm just gonna keep this pressure on, right? How much pressure should you apply? I think that's an experience thing. It's very, very hard to deconstruct that. And you can see that we have had some impact on it. We made it wider. And probably I can pass this, but let's just go back to the discussion about incisional therapy for a second, because I think it's something which you don't often get a chance to show. don't you worry, because down here there's another very nice stenosis for you to approach. So I think we can do that. First, shall we put some contrast down and assess the second stenosis? So you want to do that?
Yeah.
And then we'll come back to the incisional, and then we'll do the second stenosis with a balloon. Okay, so suction the lumen a bit before you do that, because we don't want the whole lumen really open. We're really interested in the second one, not the first one. So you can sit your endoscope here. Okay. Now, you need a control shot. Wait, you have one, right? You have a control. What is a control shot?
To see that it's in the right position.
Yeah, also, because if you're having any leaking later or you're having any problem later, you want a shot which shows the normal situations, and you just want one tap, right? We absolutely want to minimize the use of X-ray, okay? So everything possible to minimize it. No positioning this before you have the laser light. You can see probably on the screen the laser light. I don't know, you can't, but we have a laser light to localize the X-ray positioning in the center of the patient. Neither we nor the patient needs more X-ray than is necessary, right? Okay. All right. Then we're going to put contrast down then. You can flush all that down there. What is this? How many? 50%. Okay. And you can step on the, yeah, put the half and then put your foot on there. Yep. Okay. Go. Go again. More. Stop. Okay. So we already know what we need to know. Okay.
Yeah.
So let's just consider the X-ray image. Maybe, Carrie, you can prioritize the X-ray image for a second. When you're looking at the X-ray image, you can see that so there's some features of the X-ray image, right? One is that I think I can point on it. I know that. Yeah, I can point on it. So here you see where my mouse is, the tip of the endoscope, right? Here you see that, and that is sitting on, you can see endoscopically, it's sitting on that stenosis. Then you can see that below it, there's a little distance until we get to this quite annoying looking thing. So how can we, and you can see that below it, it's open. Where's the diaphragm here, right? So you know that the diaphragm is open. We've got a mid-esophageal stenosis of X centimeters. We can measure that in a minute. And you've got the endoscope here. So does that change our strategy?
For the first ring? No.
Well, but I want to now talk about green endoscopy, conserving materials. We don't really want to open two dilators, right? Two dilators, there's a lot of plastic in there. If we possibly can avoid it, we will try not to open two. So 2 bits of information can help us about whether we have to open two or not. The first bit of information is the width on X-ray of the stenosis here. Mm-hmm. And the second is what it got dilated to before. So before it got dilated to 12, we saw that on the slide. So that's very important information. The top stenosis is not really relevant at this point, apart from we know that it's quite open. So probably going to need a big dilator. And the second thing is the length of this. So what do you estimate that to be?
3 centimeters?
Mm-hmm. 3 centimeters, yeah. Oh, we just don't know, do we? And I think I'm going to fail here to be able to do this measuring on this. Yeah, do it there, yeah, let's try it, okay. And then we have to do this, but I think we first have to calibrate. What is the tip of the endoscope? So just measuring the calibration here, this tip of the endoscope, I think is 9.1, we said. Have we got keyboard? Nice. Yeah, nice. 9.1 millimeters. Okay, if we close this now, then we can go okay, and then we can try to measure it here. All right, so then we have got the idea. Oopsie, not too bad, eh? Yeah. Pretty good. Okay, so we know how long it is. That's a great thing about X-ray. You can measure on it, but you have to calibrate it to something, and the endoscope is a good thing. The width of the endoscope is a good thing to calibrate to. Okay, so we have a 4 centimeter long stenosis, and the other important thing is how wide it is. Do you think this is very, very accurate, this? And if not, why not? I mean, it's hard to get there. Like, yeah. It's going on the fact that it's probably something like 5 or 6. Look in the distance. Take out that fluid so we can see. Can we reprioritize the endoscopy image, please? You now inflate maximally and look in the distance. So, yeah, maybe it's right.
Seems small.
It seems very small, and it tapers down, as you can see on the X-ray image. Okay, so I would suggest, based upon this, that we now choose the dilator size before we do the incisional therapy. What would you choose?
Well, the previous one was 12,
Right.
but this is like smaller than 12. Seems like smaller. I mean, since the story and the symptoms of the patient, which now has for 10 days, it was okay, and now it has it's still eating some liquid. I would go. I was actually before thinking to use the 12-15 balloon.
Okay, that's what I would do. I agree. Every piece of information. So we've spent a lot of time deconstructing what's happening. We've got an overview. We've thought about it. The bottom stenosis, my key pieces of information are the bottom stenosis has been dilated to 12 before. We want to try and get it more. I would take a 12 balloon for that. We want our target would be 12. And the top one, our targets may be 15. So if we took a 12, 15, we could try to avoid the material. And I think incisional therapy, what is the benefit of incisional therapy? For the top, let's first needle knife. The benefit of incisional therapy for the top is to get it to open in a systematic way. Okay, so let me do the incisional thing and then you do the other thing. A cap is actually quite useful for incisional therapy. We'll try without it, but if we need it, we will. Other people got comments on this while we're just preparing the needle knife?
Michele has a comment.
So in the stenosis, in the distal part of the stenosis, we can see some fibrin. It's something that scares you, or it's just the healing of the previous one, and you are pretty comfortable with it?
That's a very important point, a very good point. I would say that the answer to the question is multifactorial. It's partially related to it's partially related to the pathology that caused this problem, Barrett's esophagus, and the reflux of acid, that it's not healing so well. Of course, this patient's struggling to take the PPI because it's not going down, so he's having it in liquid form. But that's part of it, right, Michele? So that's step one. That's step one. And step two, I think, of your question was about, does that scare me for dilation? Not really, but let's come to that in a second. Right, open it. Right, close it. Okay, connect it, please. So now the most important thing about incisional therapy is to think about, have I got room off the wall? What do I mean by that? Well, if you just look at this, and I'm going to push this down so you can see, underneath here, you see that there is clearly scar before I get to the wall, right? If the scar is on the wall at any point, and so I mean, like when I'm pushing it down a bit like this, right, where you can see it's in continuity with the wall beyond, it's not a great target for incisional therapy. Up here, I have the impression that I cannot push this away very much, right? I cannot push down it. So this is a good target for incisional therapy because there's kind of a web in the way. Do you kind of see what I'm trying to say? So I'm trying to say that this distal part, or this cranial caudal part, is separated clearly in luminal space, as in the scar is more towards the center of the lumen than the rest of the wall. If the wall, if the caudal wall is on the same plane as this, you're not going to get a benefit from incisional therapy, and you risk making a hole, is what I'm trying to say. So in this case, we could actually probably do incisional therapy in 4 quadrants, I would say. And let's just try and get a good position. The cap may well help us, but let's see how we get on. Okay, open it. So what we're trying to do is get a view where we can actually see what's going on with this thing. Maybe you have to be a little patient. We have to submit this to this. Okay, we need to get stable, right? So we're pretty stable here. What you absolutely cannot be is totally compressed in like this, right? If you're in like this, you're gonna make a hole. You need to have all the control on the up, down, and you need to be just sitting on the surface, okay? If you're sitting down, then you're going to really cause a major problem because this thing is just gonna cut right down. We want endocut eye effect 1. So essentially the papillotomy setting, and this is a papillotomy knife for doing pre-cut, I think. Okay, so I'm going to press the pedal 1 time. Okay, and a little bit more, and a little bit more maybe. So already I made a nice incision here, okay? And I'm going to keep going around so that the idea being that we get this thing when we use the dilation balloon, we get this thing to open in a kind of, what's the word? Regular way. Do people have questions about this while I'm doing it? Seminar room? Now's your chance to ask questions.
Yeah, one question, David. Is this something that is in general, other than like the like general safety measures that you just outlined before actually doing the incisional therapy? Is this something that is in general safe, relatively safe to do in those patients in this setting, or is this something that should be reserved only for the most severe cases?
I think that this is something that you should try if please. This is something that you should try if you are not getting anywhere with the stenosis. Like in this patient, we are not really getting anywhere with this stenosis. When you restart, okay? All right. So it's pulled you in. So down. Okay, so come back a little bit more. We're going to have to do it in 2 parts, no problem, all right? Suction the fluid if you can. Okay, good. Now, try again. I would pull out a little bit now to stop it pulling you in later. So because you only got 2 pumps and you can pull safely. Pull a little bit more. Now you know, right? Stop, stop, stop. Now you see that just emerged a little bit like that. Now I think you know it's not going to pull you in now, okay? All right. So now I would suggest that you ask her to put a few more pumps in to get it stable. Yeah, here, right? This is going to perforate. Why? 2 points of this are going to perforate. 1 point at the tip. You see the tip is embedded in a wall behind, and it's going to just, when you press that pedal, cut directly down. So this is why this is a very difficult thing for me to watch of someone else do. The person I'm watching do it has to have the best tip control before I'm letting this out of my hand, because you need to maintain this position at all costs before you press the pedal. And then, the next thing that the person does when you're training them is they look at the pedal, right? And at that point, the scope has moved. And it makes me crazy. And then I want to take it. As a trainer, this is extremely difficult to handle. Yes, so that's really important. Thank you for reminding me to talk about follow-up. This patient immediately gets a plan for the next dilatation based on, and how is this based? It's based on the type of stenosis. So in this case, a post-ESD stenosis, the number of times we needed to do it before, and the stricture that never doesn't get better. The refractory nature of the stenosis is the next thing. And so these patients, if you leave them too long, like if you leave them 4 or 5 weeks between, it just goes back to 0. So you have to have a structured period of dilatation for these people where they keep coming back every couple of weeks and you keep progressing it.